Thank you very much for the invitation again to speak at the Harvard Anesthesiology Update 2022. I'd like to thank Kira Mason and Sugantha Sundar for the invitation to speak to you today. I'm going to talk about pulmonary aspiration and rapid sequence intubation and discrepancies in our practice. I've some affiliations and conflicts of interest. I've designed and published the Aintree intubation catheter, but I don't get any monies from that. I'm past president of various Airway societies and the Irish College of Anesthesiologists, and I'm involved in the World Alliance for Airway Management, which runs 4 yearly World Airway Management meetings, and the next one is 2023, which I hope to see you all at. And I'm also involved in the Royal College of Anaesthetists in the UK. But I work in Dublin, in Ireland, in St. James's Hospital, which is one of the largest teaching hospitals in Ireland, affiliated to Trinity College Dublin. We do a lot of head and neck cancer cases. We have a regional maxillofacial unit, national burn unit, and I've been running the fellowship in airway management simulation now for over 12 years. And as I say, today I'm going to talk about pulmonary aspiration, rapid sequence induction, and discrepancies in our practice. I bring you back to this picture, which you've all seen, I know, in Boston, Hinckley's painting of William Morton's administration of ether in 1846. It was only 2 years after that first demonstration of ether anesthesia that this paper by James Simpson was published in The Lancet. I think it was actually the first edition of The Lancet. And it was the case of Hannah Greener, who died from the effects of chloroform following the aspiration of brandy and water. So aspiration has been controversial almost from the beginning of anesthesia. 100 years after that first administration of ether, Curtis Mendelsohn in 1946 described instance of aspiration in obstetrics, and which was as high as 1 in 667 cases, mortality 1 in 22,000, but they were all having face mask anesthesia, and anesthesia was being delivered by inexperienced residents. In 1961, again in The Lancet, Brian Selick described cricoid pressure, the very first description of cricoid pressure to control regurgitation of stomach contents during induction of anesthesia. He described it as backward pressure on the complete ring-like cricoid against the fifth cervical vertebra to occlude the esophageal lumen and prevent regurgitation. It wasn't until 1970 that classical RSI, as we know it today, was described by Stepp and Saffer in this famous paper from Pittsburgh, Pennsylvania, and it was published in Anesthesia and Analgesia, and it described pre-oxygenation, giving a predetermined dose of thiopentone, succinylmethonium without waiting, no opioids, cricoid pressure at loss of consciousness, no bagging or positive pressure ventilation, and not removing cricoid pressure until the ET tube cuff had been inflated. And that is what we call classical RSI, and which is still taught in certain places and was standard practice up to recently. But over 50 years later, I would suggest to you that this classical RSI is outmoded. So what do we teach our trainees? We talk about classical RSI, as I've just described, but we also talk about, I used a modified RSI. Pediatrics, they don't use cricoid pressure. What do we use for obstetrics? What about COVID patients? We say you should do an RSI on all your COVID patients. And what do I say in examinations? And I would say that in 2022, we practice rapid sequence intubation without evidence, because presently there's no standardized approach. And what about a bowel obstruction? People say, well, I do use it in bowel obstructions because of the risk of aspiration there. This is an interesting international survey about RSI, which was conducted by Markus Adovic and his colleagues. And they invited 10,000 anaesthetists to do this survey from 141 countries, with 16 international area experts then commenting as well. And the question was about a hypothetical patient with intestinal obstruction requiring a rapid sequence induction. And respondents expressed preferences varied from head up or head down position, nasogastric tube insertion and use of cricoid force were significantly preferred. But if you look at respondents from low-income countries, they were more likely to prefer supine position, nasogastric tube and cricoid force, as compared to respondents from high-income countries for this hypothetical patient with intestinal obstruction. They summarized that pulmonary aspiration is a significant cause of anesthesia-related morbidity and mortality, and high-quality prospective randomized evidence to support all strategies of prevention aspiration, such as RSI, is difficult to generate due to well-described practical, ethical, and methodological barriers. And they said they aim to generate an understanding of worldwide practice through surveying clinically practicing anaesthetists and airway experts. So this survey demonstrates that preferences of positioning, nasogastric tube use, and cricoid force application varied substantially, and particularly varied between high and low income countries. But it tells us little about what pharmacological or airway choices were preferred. So in summary, the classical RSI seems to have evolved to the extent that there seems to be widespread confusion. What we'd say when we say RSI, we say I used a modified RSI, but nobody knows what that really means. And it's not a prescriptive approach to intubation, trigeal intubation, but more tailoring practice to avoid complications in high-risk patients. But remember, although aspiration is not very common, the rate in ED aspiration associated with emergency intubation is unknown. And remember Mort's paper, which showed that on first attempted intubation, complications, adverse events are 1.9%, but can be up to 22% on subsequent attempts. And mortality from aspiration in ED has been shown to be as high as 4.6%. Also, let's look back to NAP4, the National Audit Project 4, which was done in the UK, which looked at complications of airway management throughout every hospital in the UK. Every hospital responded. It had a huge uptake, and they looked at major morbidity and mortality. So 2.9 million UK anaesthetics were assessed over a 1-year period, and aspiration was the largest cause of the highest cause of death associated with airway management in the UK anaesthesia in this study. Of the 29 aspirations, 8 died and 2 had brain damage. So the main cause, though, was inappropriate use of LMAs at that time, and that might be because they were beginning to be used widely and they were being used inappropriately. But look at one of these cases from NAP4 during RSI. This is an elderly ASA3 patient required emergency laparotomy for bowel obstruction. The patient had BMI of over 35 with a hiatus hernia, and nasogastric tube had not been passed. The anaesthetist planned an RSI modified by giving an opioid. The patient was induced while cricoid was in place. It vomited copiously, such that the airway was obstructed and the larynx could not be seen. Attempted rescue with face mask and laryngeal mask failed, and profound hypoxemia developed. Cannula carcinotomy was promptly and successfully placed, enabling reoxygenation and then intubation. Surgery was completed and the patient made a full recovery. However, this patient was a case in the NAP4 because it needed ITU and an anticipated ITU admission. But with cricoid in place, they aspirated copiously, so the air was obstructed and the larynx could not be seen. And that's significant because cricoid pressure causes relaxation of the lower esophageal sphincter and can induce gagging in susceptible patients and increase, in fact, the risk of regurgitation, and we know that. So let's look at rapid sequence induction for the 21st century. And I'd also like to introduce you to this project, the Project for Universal Management of the Airways, which I'm involved in. And this is a group of us 14 anesthesiologists with emergency physicians and intensivists from all over the continent, from 4 different continents. And we have published our content methodology paper in 2020, and are about to publish universal principles for airway evaluation, airway strategy, airway rescue, and communication of airway outcomes. And these will all be published later in the year. And that's, as I say, that's the first paper setting out the universal principles. And we have already published something on RSI. And first of all, the terminology. We don't think one should be using classical or modified anymore, just the term rapid sequence intubation. And clinicians, we feel, should use their judgment around the use of various aspects of RSI in different clinical contexts. So, and the purpose, why are we doing RSI at all? The purpose of it is to reduce the risk and consequences of aspiration during tracheal intubation. And it's called rapid, but it's not that you rush at it. It's to minimize the time interval the airway is unprotected. So it's not rushing. It's not taking heed. It's not rushing the initiation of airway management. It's minimizing the time interval. And we divide the RSI classification based on the literature review we've done for this in the PUMA group to recommended, suggested, and optional. And by recommended, we mean there was evidence or universal agreement from the various audits we've done that they contributed to the goals of RSI, but they must be implemented for an intubation to be considered an RSI. So the recommended components have to be implemented. Suggested components should typically be adhered to, but there's valid reasons a clinician may choose to omit them in a particular context. So these are suggested and may or not be used. And optional components then, these are the components that might theoretically contribute to the goals of a rapid sequence intubation, but for which there's insufficient evidence to either support or reject their inclusion of elements of RSI. So some components didn't fall into any of these categories. So which induction agent, for instance, was used? And we know from the National Audit Project 5, which is on awareness, a large activity study of every anaesthetic given in the UK, showing that thiopentone is now only used really for cesarean section RSI, ironically, not for general anaesthesia in the elderly or in adults. So really, propofol is used almost predominantly for RSI, except for cesarean sections. Now that was in a few years ago now. It might have changed slightly, but there is a move to change to propofol for all RSIs, because after NAP5 it was recommended that you should be cautious when using thiopentone because you might not be familiar with it, and perhaps changing it to propofol would make more sense. What about removal of a nasogastric tube already in situ? Again, that is not something we've included. What are the optional components now? The optional components are prokinetics, non-particulate IV antacid use, nasogastric tube placement and suction is optional. Avoidance of face mask ventilation prior to laryngoscopy is optional. Position change is optional. And avoidance of sedative or hypnotic agents prior to induction is also optional. What about cricoid pressure? That is the most debated element or component of RSI, and we have put that in the optional component, and let's look at that in more detail. Is there any evidence? Now, this is the formidable Selig, who described cricoid pressure, as I mentioned, in his 1961 Lancet paper. The Lancet accepted this observational study of 26 patients in 1961. Not sure they would today. And he described in this observational study 3 cases that regurgitated on release of cricoid pressure. He followed it up a year later with an observational study on 100 patients, but it became a standard of care, the cricoid pressure. And what force was he using wasn't mentioned at the time or didn't seem relevant, but the force required to occlude the esophagus has had many, many studies since, and particularly by Richard Vanner from the UK and Takasai from Japan have written a lot on this. And I think the standard suggested now is that you need 10 units in the awake patient, and then so it's not too prohibitive and won't make them cough, and then 30 newtons once the patient is anesthetized to safely use cricoid pressure. But cricoid pressure should be considered and implemented in accordance with the recommendations of local policies and practices, because there's lots of international guidelines out there from all sorts of societies and from various institutions, and you have to, obviously, they take precedent. But if cricoid is used, it's fine, but it should be ideally performed by a dedicated individual with no other responsibility who's capable of performing it correctly, because it only works if it's correctly performed. And we know from lots of studies that only 10% know how to correctly apply it. And staff are expected to perform who should be instructed in the correct technique for its application and should practice on scales, etc., to kind of get the pressure right. And remember that external laryngeal manipulation, which we use during intubation, is a distinct intervention from application of cricoid. It's a different purpose, technique, and mechanism of action. Now, remember always that cricoid pressure, if used, should be promptly removed if it is impairing attempts at intubation. This is because lots of studies, including Richard Levitan's work in the American and the Annals of Emergency Medicine, look at 1,500 laryngoscopies and cadavers and found a deterioration in view in almost 30% of these with cricoid pressure. So cricoid pressure creates a poor laryngoscopic view. So it should be removed if it's thought to be impeding adequate mask ventilation also, and prior to insertion of a supraglottic airway for airway rescue, because your supraglottic sits in the cricopharyngeus and will not sit properly if you have cricoid pressure inside you. So see, cricoid pressure results in difficulty placing it because it impedes placement and impedes ventilation. Again, lots of work on this. So remove also if patient shows active signs of vomiting. Now, I'm going to just present you with this coroner's report on the fatal inquiry into the fatal accident into the death of Gordon Ewing by the coroner Linda Ruxton in Scotland. And this is a published coroner's report. This gentleman was 44 years old. He fractured his middle finger and he was coming back for a second anaesthetic to remove the wire. He had a history of reflux. The plan was to do an RSI with propofol, sucks and cricoid pressure. First attempt with a Macintosh laryngoscope blade, standard blade, and they got no view of the larynx, but the comment was made that the hand applying the cricoid pressure was in the way. They persisted with cricoid, and a second attempt was made, and there was no view of the larynx after 3 minutes, and there was blood noted in the mouth, and they proceeded to abandon intubation and put in an LMA. Now, they ran into difficulties placing the LMA. They ran into difficulties intubating through the LMA, persisting. And sadly, this patient succumbed eventually from attempts at exchanging a tube and barotrauma. But the point was the problems that started right at the beginning of this case at laryngoscopy, in that the difficulties were associated probably with obstruction caused by the hand of the assistant applying cricoid pressure, and then led to the slippery slope of this patient's demise. And the coroner made this point that this was the cause. So it's a lesson that we learned from this coroner's report, that be careful with your cricoid pressure. I'm just going to mention the IRIS RCT here. This IRIS study, random controlled trial, looked at the effect of cricoid pressure compared with a sham procedure in RSI of anesthesia. And it was published in JAMA in 2019. It was the first ever randomized double-blind non-inferiority trial of cricoid pressure. And the results failed to prove the non-inferiority between sham, Sellick maneuver, and cricoid pressure. The study was underpowered, however, but pulmonary aspiration was compared between the two groups, and 0.6% in the cricoid Sellick maneuver versus 0.5% in the sham. So failure to prove the non-inferiority. However, there was a higher incidence of Cormack-Lehan grade 3 and 4 in one group, and a longer intubation time in the patients who had Sellick maneuver. So Sellick maneuver perhaps leads to decreasing your Cormack and decreasing your Cormack and Lehan. So in other words, higher grade and longer intubation times. So now that was an optional component. Now back to the suggested components. The suggested components are apneic ventilation during attempts at laryngoscopy. This is a good thing, and you might consider it. Apneic oxygenation via nasal cannula during attempts at laryngoscopy. Bed trolley, place the bed in the Trendelenburg if regurgitation occurs. Leave suction and leave it open to air, and if you have an in situ nasogastric tube, and that's considered suggested and maybe good practice. But what about the recommended components? The recommended components are what it's all about. This is what RSI. To have an RSI, to put it in your chart, it must have the following components: pre-oxygenation, suction on and under the pillow, confirmed reliable IV access established, tracheal introducer prepared for use, a predetermined dose of induction agent, no latency between giving your induction agent and the neuromuscular blocking agent, use of rapid onset neuromuscular blocking agent, apneic oxygenation between attempts at laryngoscopy, if positive pressure ventilation not used. Confidence in complete paralysis prior to instrumenting the airway. And tracheal tube inflation prior to positive pressure ventilation. Now, these are what PUMA suggests are the recommended components of RSI. Now, they might seem quite similar to something we have been very close to our hearts, the consensus guidelines for managing the airway in patients with COVID-19. These were developed in March 2020, about 10 days after the major outbreak of COVID-19. They were jointly written by the Difficult Airway Society, the Association of Anaesthetists, the Intensive Care Society, and the Royal College of Anaesthetists, and have been widely used. And they recommended RSI in all patients. And these are other guidelines as well from the Italians, and they should suggest apply cricoid pressure only in cases of ongoing regurgitation. And using cricoid pressure in COVID, the Society of Airway, the Safe Airway Society in Australia said that palpating of the cricoid cartilage may inadvertently encourage clinicians to lean in closer to the patient's airway, and giving its highly simulating nature, it may precipitate coughing, which we know is one of the most AGP generating, aerosol generating things. Coughing is more aerosol generating than intubation. So in view of the limited evidence for its effectiveness, the risk benefit of application of cricoid pressure should be carefully considered. So during the COVID time, I think people were moving away from cricoid pressure as part of the RSI, although we're saying do an RSI. So obviously it's an optional component. Again, these guidelines were saying full dose neuromuscular block, and again, using video laryngoscope to optimize first laryngoscopy. Also having a bougie ready with your ET tube, and as I say, using a video laryngoscope preferably. So these guidelines from the DAS and the Royal College suggesting safe, accurate and swift intubation, and again, very like the RSI guidelines which I've been describing there from PUMA. And the Safe Airway Society also, the Difficult Airway also decided, said it should be safe for staff and patient, accurate, so using reliable, familiar techniques, and swift, timely, without rush and delay. So I think airway management may have changed forever since the COVID era, in that we are now suggesting universal VL, and again we're suggesting that for RSI because you want to get success at first attempt. Second generation if that fails, and key principles: preparedness, standardization, and choice limitation. So RSI for the 21st century, any interventions considered to facilitate rapid and reliable intubation are encouraged. And here are the PUMA recommended, suggested, and optional components of RSI. Recommended are the components that you must always use if you put in your chart that this is a rapid sequence induction. Suggested, if you feel a good idea, and optional components are the ones that I mentioned, including cricoid pressure, for which unfortunately there is very little evidence. So the full PUMA guidelines will all be available in 2022. So, and in addition, there will be an associated training program. And at the WAM meeting in 2023, we will be presenting these. This is the PUMA working group, and this is the first time we met face-to-face in Amsterdam at the WAM meeting there in 2019, and we haven't obviously met face-to-face since, but hopefully we will soon. And just this is another editorial which I'd like to bring to your attention from Karim El-Baghdadi from St. Guy's in London, talking about time for consensus and rapid sequence intubation. And future directions, I think, are, we must remember there's inconsistency in our clinical practice, there's absence of high quality data, and we still need more research in general on aspiration. We need role of the gastric ultrasound in RSI, and some data on point of care gastric ultrasound for the residual gastric volume, the antral area measurement could be promising. So there's hopefully will be more work on that. Optimal patient positioning, whether the head-up position is associated with increase in FRSC, improving pre-oxygenation and longer time desaturation. We need more evidence for that. And the true impact of cricoid force on patient outcomes following RSI in different patient settings. So I think we have further work to do. So I think RSI is all about balancing risks, balancing the risks of difficult intubation, awareness, trauma, failed intubation, and death with the low risk of aspiration. So thank you very much for your attention, and I'm very happy to take any questions you might have on this topic at the end of the session. Thank you.